So what is sequestrum? Before we know sequestrum, we have to know about osteomyelitis. Osteomyelitis denotes inflammation of the bone and marrow, virtually always secondary to infection. Osteomyelitis frequently manifests as a primary solitary cause of disease but can also be a complication of any systemic infection. All types of organisms, including virus, parasites, fungi, and bacteria, can produce osteomyelitis. But most common is certain pyogenic bacteria and mycobacteria. Pyogenic osteomyelitis is almost always caused by bacterial infection. Organism may reach the bone by hematogenous thread, extraction from a contiguous site, and direct implantation. Staphylococcus aureus is responsible for 80 to 90% of culture-positive pyogenic osteomyelitis. This is the most common organism, Staphylococcus aureus. Then E. coli, Pseudomonas, and Klebsiella are more frequently isolated from individuals with genitourinary tract infections or intravenous drug abusers. Haemophilus influenzae and group B streptococci are common in neonates and sickle cell disease predisposed to salmonella infection. Now the clinical features. Hematogenous osteomyelitis may present acutely as a systemic illness with malaise, fever, chills, leukocytes, and intense throbbing pain over the infected bone. Now mycobacterial osteomyelitis. Mycobacterial osteomyelitis tends to be more destructive and resistant to control than pyogenic osteomyelitis. Risk of mycobacterial osteomyelitis increase in those with pulmonary or extrapulmonary tuberculosis, up to 3% of whom have osseous infection. Clinical features: localized pain, low-grade fever, chills, or weight loss. Now the morphology. In the acute phase, bacteria proliferate and recruit neutrophils to the site. Necrosis of bone cells and marrow ensues within 48 hours. Bacteria and the associated inflammatory response then spread longitudinally and access the Haversian system to reach the periosteum. Because the periosteum is loosely attached to the organs in children, subperiosteal abscess may form. Then associated periosteal lifting further impairs blood supply and contributes to the necrosis. Soft tissue abscess may also form after periosteal rupture, and this can channel to the skin as draining sinus. Dead bone or sequestrum can crumble and release fragments into the sinus tract. So sequestrum is dead bone. As the inflammatory process evolves, chronic inflammatory cells recruited during the first week release cytokine that stimulate bone resorption, fibrous tissue ingrowth, and peripheral deposition of reactive bone. This new bone can form a living shell that is called involucrum around the devitalized infected bone. So new bone is called involucrum. Now giant cell tumor. Giant cell tumor is characterized by the presence of numerous multinucleated osteoclast-type giant cell. It is also called osteoclastoma. Although giant cell tumors are benign, they can be locally aggressive, but basically it is a benign tumor. This uncommon tumor usually arises in the 3rd to 5th decades of life. Giant cell tumor develop within the epiphysis and may extend into the metaphysis, majority near the knee involving distal femur or proximal tibia. But virtually any bone can be involved. Because they typically arise near joints, giant cell tumor may cause arthritis-like symptoms. They can also present with pathologic fractures. Now, morphology. Giant cell tumor often destroy oval-like cortex, resulting in a bulging soft tissue mass delineated by a thin shell of reactive bone. Grossly tumor are large, red-brown masses that frequently undergo cystic degeneration. Histologically, the tumor consists of uniform, oval, mononuclear tumor cells and abundant osteoclast-like giant cells. So, histologically, the tumor consists of uniform, oval, mononuclear tumor cells and abundant osteoclast-like giant cells with 100 or more nuclei. Necrosis and mitotic activity may be prominent. This is the giant cell tumor in the proximal part of fibula, and here is the pathological fracture. This is the tumor. Expansion lytic lesion. This is the microscopical image. These are giant cells. These are all giant cells. Multinucleated giant cells. Now, osteosarcoma. Osteosarcoma is the most common primary malignant tumor of bone and accounts for approximately 20% of bone cancers. The age distribution of osteosarcoma is bimodal, with 75% occurring before 20 years of age. Men are affected slightly more than the women. Ratio is 1.6:1. Although any bone can be involved, tumor usually arises in the metaphyseal region of the long bones. Almost 50% are near the knee in the distal femur or proximal tibia. Osteosarcoma often present with pain, sometimes due to pathological fractures. Radiographically, mixed lytic and blastic mass with infiltrated margins. The tumor frequently breaks through the cortex and leaves the periosteum, inducing reactive periosteal bone formation. The triangle shadow between the cortex and the rest periosteal end, known as radiographically Codman triangle, indicates an aggressive tumor. Morphology. Osteosarcoma are bulky, gritty, gray-white tumors that often contain hemorrhage and cystic degeneration. The tumor frequently destroys the surrounding cortices to produce soft tissue mass, spread extensively in the medullary canal, and replace hematopoietic marrow. Tumor infrequently penetrate the epiphyseal plate or enter the joint. Osteosarcoma demonstrate pleomorphism, large hyperchromatic nuclei, bizarre tumor giant cells, and abundant mitosis including abnormal forms. Extensive necrosis and intravascular invasion are also common. Diagnosis of osteosarcoma requires the presence of malignant tumor cells producing unmineralized osteoid or mineralized bone. This is the distal femur osteosarcoma, and you can here see the Codman's triangle. This is the Codman's triangle. Osteosarcoma of the proximal tibia. This is the tumor mass. This is the tumor mass. Clinical features. Based on their known natural history, all Osteosarcoma patients are assumed to have occult metastasis at the time of diagnosis. As a result, treatment generally includes neoadjuvant chemotherapy, surgery, and postoperative adjuvant chemotherapy.